Thank you very much, Jose, for inviting me to the stage. It's, as I mentioned earlier, a great pleasure to be here, and also I applaud you for your resilience and non-fatigability after a dense day of very important information. So food for thought and food for guts. So I've been tasked to discuss the management of MS in older patients, implications of immunosenescence, and how in this scenario cladribine may take a more important role. So what I will discuss in view of the fact that, populations are getting older, as are patients with MS. And interestingly, as a sideline, the frequency of late onset multiple sclerosis has also been on the increase. So we are talking about unmet needs in older adults with multiple sclerosis. What are the treatment challenges that we face? What impact does this concept of and fact of immunosenescence have on the immune system? Why is the infection risk such a crucial consideration, particularly in patients of older age? And how does the nature, the face of MS change as patients get older? And finally, in this regard, how do comorbidities, cognitive impairment, and polypharmacy indicated for the various comorbidities that also increase with age impact the management of our patients? And then I will focus against this background what role cladribine tablets could play in the management of older patients with relapsing MS, and will briefly review clinical and real-world data. And with this, I'd like to answer or try to answer the question, why may cladribine tablets be suitable for a wide range of patients? Did cladribine tablets show sustained efficacy in patients of higher age? Did cladribine tablets sustain a favorable safety profile in this population? And how, finally, how may cladribine tablets be considered as a de-risking option in older adults with relapsing multiple sclerosis? So there are additional treatment challenges, including age-related changes in the immune system, and age-related changes in MS and the response to disease-modifying therapies. And I will briefly review the data demonstrating that cladribine tablets are equally effective in, if you make the cut, patients below age 50 and above age 50. And as was mentioned by Dr. Flores, cladribine has a lower burden due to the classification as an immune reconstitution therapy than other therapies, particularly, of course, for the patients, but if we consider it in the broader context, to the caregiver, to the medical system, and society at large. And the final section of my talk will be devoted to the issue of de-risking and how cladribine could play an important role in this situation. So, again, sustained high efficacy benefits across various outcome measures without continuous immunosuppression, one unique benefit offered by cladribine tablets. The observed impact on markers of inflammation due to the effects on the immune system, both in the periphery but also in the central nervous system. And again, the low treatment-related burden, which makes this therapy suitable for a wide range of patients. This is shown in cartoon fashion to demonstrate the various age stages and situations where cladribine may offer a favorable clinical benefit in treatment-naive patients, in those that for a number of reasons may be switched to cladribine after other disease-modifying therapies, for patients in their productive years, and this is what I will focus on, in older adults and patients with comorbidities. So again, what are the treatment challenges? And here we look at the changes that occur in the immune system, and these are referred to as immunosenescence. But also the changes in multiple sclerosis that occur with advancing age, and the changing response to disease-modifying therapy. So the increased infection risk resulting from immunosenescence and the potentially diminished efficacy of disease-modifying therapies are the reason to reconsider and reassess the benefit-risk ratio of different DMTs. And as I mentioned earlier, older adults are also more likely to have increased comorbidities, cognitive impairment, and polypharmacy. Now, if we look at the data of the efficacy of cladribine comparing younger and older patients, this is from the pivotal Clarity trial, a post hoc analysis, it's clear that the effect compared to placebo, and remember this was more than 15 years ago when the trial was ongoing, so it was compared to placebo, showed a marked diminution in annualized relapse rate in patients less than 50 years and those above 50 years. And these results are corroborated by real-world studies, just example from the US and from an Italian-Swiss study looking at annualized relapse rate, EDSS, in dichotomizing the age below and above 50 and the rates of NIDA, no evidence of disease activity, as was already alluded to by Dr. Flores in his talk. Now, very importantly, the drug was in general, well tolerated in the older adults, and the pharmacokinetics in terms of lymphocyte depletion and recovery were similar in patients aged less than 50 and above 50. And this is shown in during 2 years. Let me just go back, where you can see that the lines reflecting lymphocyte levels, which rarely go significantly below the ALC range, were almost superimposed in these two age groups. And the incidence and duration of grade 3-4 lymphopenia, so a higher degree of lymphocyte depletion, was found to be similar in the two cohorts. So again, to emphasize this concept that this kind of immune reconstitution therapy, and it was in actual fact the introduction of cladribine and attempts to define its mode of action that generated this concept, clearly has advantages. compared to short-term intermittent drug administration, there is clinical efficacy beyond active dosing. So, as initially already mentioned, the age distribution of MS has changed over the past couple of decades or so. This is a study from 2019 looking at the prevalence in 2010 of MS accumulated over 10 years, and you can appreciate that the prevalence in the age group above 54, 55 increased significantly. Now, this may be a reflection of the general increase in age in the population. It may be due to increased incidence. There is data out there, somewhat controversial though, and of course an increase in prevalence due to a better therapy of comorbidities and better therapy of MS itself with DMTs. So we will see, and we are seeing, more patients with MS in the older age group. This then brings me again to this concept of immunosenescence, which basically describes the age-related changes, the decline in immune functionality in older adults, and what implication these changes have. If we look on the left and right-hand side, we see the impact on cognate immunity mediated by T cells and B cells. So we have a loss of naive T cells. We have a restricted T cell receptor diversity, reduced proliferative capacity of T cells, an increase in memory B cells, which are considered to drive the autoimmune responses, along with a decrease in naive B cells, a decline in B cell numbers, and decreased responsiveness to novel antigenic stimulation. Now, these factors on the immune responses put patients at an increased infection risk, at an increased risk for severe infection, and makes them susceptible to a reduced, diminished vaccination response. And the latter we came very painfully aware of in the wake of the COVID-19 pandemic. If we take a closer look, I don't want to run again through the effects on T cells, B cells, but they are quite diverse. But let's have a look at cells in the central nervous system, microglia, oligodendrocyte progenitor cells, critically important if there is need for remyelination. They need to differentiate in fully competent oligodendrocytes and astrocytes, and you see the functionality of these cells again being affected by aging, basically promoting if you like, a pro-inflammatory situation. So the risk of serious infections, and this has always been a concern when impacting significantly in immune system by therapeutic intervention, is correlated with the duration of therapy, prior immunosuppressive therapies, and we've become aware of this in the context of PML associated with natalizumab, lymphopenia, reduced IgG, AM levels, hypogammaglobulinemia, and comorbidities. And you may remember when one looked at the occurrence of PML with natalizumab treatment, again, patients at higher age were more susceptible to the occurrence of this fortunately relatively rare but dreaded complication of natalizumab. So this is just to reinforce this and use the example of anti-CD20 therapies, where an increased frequency of infections in the older population with longer treatment duration has been well described. And you also know that there is an increased risk for the occurrence of cryptococcal infections when patients are on fingolimod, and this risk is higher again in old age. Now, also, as I mentioned, there are changes in the pathobiology of multiple sclerosis, its clinical manifestations over time, resulting, as you heard earlier, in a decrease on MRI activity and relapse rate. However, there is also a loss of recovery from the relapses and increased disability worsening. There is a diminished capacity to remyelinate due to impaired phagocytosis of myeloid cells, including microglia, and reduced functionality of the precursors of oligodendrocytes, and an increase in brain atrophy as an overall aggregate of the destructive tissue changes in the CNS and a decreased CNS tissue reserve. Now, the question has been addressed whether particularly high efficacious treatments are or remain the same with advancing age. And this is a famous, frequently cited study from the NIH, from Belakova's group, demonstrating that over the years, the efficacy of these high effective treatments, alemtuzumab, mitoxantrone, natalizumab, ocrelizumab, went down, and they claim, these authors claim in the meta-analysis, that older patients receive reduced benefit from these treatments, and they say that in their analysis, in patients beyond age 53, there was no predicted benefit. And they also say that high efficacy treatments were only superior to low efficacy therapies in younger patients. I think one has to take this with a grain of salt. So again, we need to consider the impact of comorbidities, and this is just an analysis of the prevalence along the course of not the disease, but in general of the population. You see depression, hypertension, hyperlipidemia, and so on and so forth. You heard this earlier today. And you can clearly appreciate, this is the blue line, that in older patients, the frequency of these comorbidities increases, complicating the management of the patients. So these older adults are more vulnerable to the risk associated with polypharmacy, indicated because of the comorbidities. And you can here see that, of course, older patients more frequently receive polypharmacy. And this is, amongst other things, associated with an increased level of fatigue and cognitive impairment. There is a longer disease duration, an increased risk of drug-drug interactions, and hospitalization. So also a poorer adherence to treatments by patients. And this demonstrates what is obviously clear, intuitively plausible, if you like, that cognitive impairment as patients get older. And you all know that this is a very fundamental, major symptom and impairment in multiple sclerosis, and again, more prevalent in older adults. There are other ways to assess health outcomes. This is an example where infections and the use of skilled nurse facilities were looked at and compared, and they were found to be more frequent, again not surprising, in adults aged 50 or above with MS than those without multiple sclerosis. Also, the time to first walking aid or the requirement for wheelchair use was significantly shorter in adults aged above 50 compared with those without. Now we address the issue of discontinuation of DMTs in older patients. Again, in view of the multiple confounding factors that may put patients in this age group at a higher risk, one considers to discontinue DMTs. But beware, there is the risk for developing recrudescence of disease activity following discontinuation, and this is demonstrated here, where disease activity was lower with sustained DMT therapy compared to those that were, for a number of reasons, discontinued. So again, this combination of factors mandate a continuous and renewed assessment of the benefit-risk ratios. Can the DMT therapy be continued in the same fashion with potential new risks? And here comes the point where we'll discuss that cladribine tablets are a treatment option in older adults with relapsing multiple sclerosis. And this goes back to the pivotal phase 3 trial, Clarity, that I referred to earlier, and the post hoc analysis published some 7 years ago to demonstrate again that there was no difference in efficacy comparing the two age cohorts. If one looks at MRI outcomes in patients below and above 50, again in terms of T1 GET enhancing lesions reflective of acute inflammatory activity and active T2 lesions, there was no significant difference in the two age groups as regards the response to cladribine. I showed you this slide before and want to just reinforce this concept that the degree and kinetics of lymphocyte depletion was almost identical in patients below and above 50. And I also briefly drew your attention to this fact that the severe lymphopenia was similar in the two age groups. If one looks at the long-term effect of therapy here from a US real-world study monitoring patients over 5 years, again you see that there is sustained efficacy, and it was clear that there was no diminished efficacy if one looked at the higher age group of patients. And this is a listing of AEs that were studied in this US real-world cohort. And basically, those were similar. There were some slight increases in infections, not serious infections in the older age group, but by and large, these AEs were comparable. This is what Dr. Flores also mentioned earlier, neither 3 as an aggregate outcome, reflecting both clinical and MR effects. And again, looking in this Swiss-Italian cohorts at the effect of attaining NIDA 3 with cladribine in patients below and above 50, and again showing almost identical results. And again, looking at the lymphocyte levels over 6 months, there was no difference discernible. Now, in the final section of my talk, I will address the issue of de-risking strategy that could be achieved with cladribine in older adults with relapsing multiple sclerosis. Now, de-risking is a treatment option. Staying on continuous immunosuppressive therapy in this complicated situation of older age may increase the potential for infections and also reduce in poor adherence due to continuous administration. Now, on the other hand, the discontinuation of therapy that may be considered as a response to a reduced benefit risk profile of DMTs in older adults may be associated with the potential for recurrence of disease activity and even rebound, in particular in patients on lymphocyte trafficking inhibiting drugs like natalizumab or the S1P receptor modulators. So one potential to overcome the problems associated with such an approach may be the switch to an immune reconstitution therapy, a different mode of action of intervening with immune responses. This is, again, from a US real-world study showing that switching from any of these drugs to cladribine tablets was well tolerated in this age group. Reasons for the switch were multiple. Of course, the perception that one no longer experienced the degree of therapeutic benefit, that there may be the perception of risk to have more infections and the experience of less lymphopenia. So common adverse events before switching included recurrent opportunistic infections, and no cases of infections were reported in patients after switching to cladribine. And I will just show you different classes of DMTs that were stopped and patients switched over to cladribine. This is the swingazine 1-phosphate receptor modulators, looking over a period of 3 years, where the annualized relapse rate in patients that had been switched went down and stayed down, and you also see the lymphocyte counts over 104 weeks after switching to cladribine tablets with a typical pharmacokinetic and a recovery of the lymphocyte counts very similar to what I showed you before. Now let's look at natalizumab and the sustained treatment effectiveness of cladribine. You see the baseline, 0.1 analyzed relapse rate, and month 12 and 24 to almost 0. And the reduced analyzed relapse rate also was reflected in the lack of hospitalizations. This is shown after the switch baseline through year 3, where it was 0. And now, as the third group, patients who switched from anti-CD20 B-cell depleting therapies in older age, again with the idea that this may lessen long-term immunosuppression, and the reasons were listed in the same manner as before. This is from the same US cohort. Don't want to go into the details, but common adverse events before switching included, again, recurrent opportunistic infections and reductions in immunoglobulins. But after the switch, no cases of infection or concerning immunoglobulin reductions were reported. This is to show you that following switch from ocrelizumab to cladribine, there was a significant increase in the previously lowered IgG levels. And again, looking at annualized relapse rate and hospitalization rate following the switch from ocrelizumab to cladribine, a very effective and sustained effect. So the outcomes for patients treated with cladribine as the first DMT or after switching from other DMT platform therapies or highly effective therapies is shown here, and were very similar and a very high degree positive in terms of clinical and MR disease activity. This is a summary then of the cohorts studied across the world, including the largest, the MS base, that in aggregate support the findings that I briefly summarize. And coming to a close, I just want to re-emphasize that cladribine tablets may be suitable at various stages of multiple sclerosis, from younger to older age, that there is sustained efficacy and a sustained safety profile in the older age group of patients with relapsing multiple sclerosis. Sorry, I went the wrong way. Yeah, and I'd like to conclude by providing some recent reviews that may be helpful in looking at the management of patients with older patients with MS and the issue of de-escalation. It was very recently the outcome of a ECTRIMS-sponsored workshop on this issue. And with this, I'd like to thank you very much for your attention.